Hi, so I'm going to be talking about depression, the patient assessment and management. Case presentation. So, John Lan is a 43-year-old male who has had a myocardial infarction 4 months ago. He asked if you can do a checkup for his heart. When you talk to him, he looks towards the ground, very tired, drained, and very tearful. How would you assess and manage him? My provisional diagnosis for this patient is that he has major depression, which is characterized by at least one major depressive episode, at least more than 5 of these episodes for at least 2 weeks, a depressed mood, anhedonia, loss of interest in pleasurable activities, change in appetite or body weight, increasing or decreasing feelings of worthlessness or excessive guilt, insomnia or hypersomnia, diminished concentration, psychomotor agitation or retardation such as restlessness or slowness, fatigue or loss of energy, recurrent thoughts of death and or suicide. An easier way to remember all of that is SIGE CAPS, which is a mnemonic. It's useful to remember the diagnostic criteria for major depressive disorder. So S stands for sleep changes, I interest lost, G guilt or worthlessness, E energy loss, cognition or concentration difficulties, A for appetite loss and or weight loss, P for psychomotor, S for suicidal ideation. In terms of differentials, it's important to think that there are a number of secondary medical causes that need to be considered in a patient who you think has depression. Other medical causes can be neurological causes, such as Parkinson's disease or cerebrovascular disease like vascular dementia, malignancies like lymphoma or pancreatic, endocrinopathies, hypoglycemia, hypothyroidism, autoimmune causes such as SLE, also drugs, ethanol, sedatives, barbiturates, anticonvulsants, antipsychotics, corticosteroids, interferon, levodopa, and withdrawal from psychostimulants such as cocaine and amphetamines can also make the patient seem quite down and depressed where they're really not depressed. So, if this patient does have depression, there are 4 unique types of depressive disorders, the most common being non-melancholic, which accounts for more than 90%. Then you have 3 other ones, so melancholic depression, atypical depression, and psychotic depression. So, we'll go through each of these. So, non-melancholic depression is the most common form of depression and has a very high rate of spontaneous remission, which is great. It has to do with stressful events in a person's life, and when these stresses leave, the depression often improves. They experience a depressed mood for more than 2 weeks with social impairments such as difficulty dealing with work or relationships, and they can be cheered up somewhat, and they also respond quite well to psychological treatments such as counseling. Now, just keep these in mind as we go through the next 3 different types of depression. So, melancholic depression is somewhat a biological depression. So, people think it's like an imbalance of neurotransmitters within the brain, and they have an extreme lack of pleasure, and it's very hard for them to be cheered up at all. And they also have some psychomotor disturbances such as low energy, poor concentration, slow or agitated movements. The next one is atypical depression. It's atypical because usually people lose their appetite when they're depressed, but for these patients, the appetite increases, and also they feel quite sleepy through the day, so they just kind of eat and sleep. And they also have this interpersonal hypersensitivity where they expect that others do not like them. Other features is that they are able to be cheered up, and they often have significant weight gain, appetite, and sleeping, and they feel heavy in their arms and legs. And they're very quick when people reject them. They feel very sad. So they're always there trying to please other people. There's psychotic depression. These people have a severely depressed mood, severe psychomotor disturbances, psychotic symptoms, delusions or hallucinations, with delusions being more common, and a very low spontaneous remission rate, and only really responds to treatments like antidepressants. But counselling would also be a good trial for these patients as well. In terms of history, when you encounter these patients, you want to really try and establish a good rapport with them, because they are often maybe reluctant to discuss and disclose how they're feeling, and you need that for the diagnosis. You want to focus on the symptoms by using SIGE caps to see whether they have depression, as well as their chief complaint. For the current episode, you want to ask why they came, any description of what they're going through, any things that happened in the past, because you're thinking more of a non-melancholic. If they just feel sad despite their life being a very, very easy, you're thinking more of a melancholic depression, and that's harder to treat. And also assess their risk. This is quite important. You really want to make sure that this patient is at no risk of suicide or harm to others, because if they are, as a doctor, you are under law to assess them and manage them in a way that minimizes harm to both themselves and to others. You want to screen for other symptoms of psychiatric illnesses, such as bipolar or schizophrenia, because they often come together. And you also want to focus on some past medical psychiatric history and risk factors for depression, whether they've had any stress in their relationships, financial, legal, domestic violence, or gambling. And also screen for secondary causes of depression, such as whether they've had increasing memory loss for dementia, cerebrovascular disease, anemia, hypothyroidism, and drugs, because these can mimic depression, especially hypothyroidism. They have weight gain, they feel very tired. Family history, those who have a family history of mental illness have an increased risk of having mental illness themselves, as for medication allergies and psychosocial history. In terms of examinations, you want to look at any relevant symptoms that could be contributing to the depression. You want to do a mental status examination, which focuses on the appearance and behavior, content, delusions, emotions, thought flow, grave risks, hallucinations, insight and judgment of the patients. You also want to do an anxiety and depression checklist, such as the K10 or the Geriatric Depression Scale, and an MMSE, mini mental state examination, just to see how they're doing cognitively. After this, you devise a formulation for the patient's disease, assessing the presence of the 4 Ps: predisposing, precipitating, perpetuating, and protective factors for this patient. In terms of investigations, you can do a full blood count to exclude anemia as a cause for the lethargy, and a thyroid function test whereby our elevated free thyroid stimulating hormone indicates hypothyroidism. So usually people do TSH by itself just to screen for it, and if it is elevated, they do the whole screen looking at T4 and T3. In terms of management, the management of depression uses a biopsychosocial model, and it really requires a multidisciplinary approach. So you need the community mental health care team involved, general practitioners, and treating psychiatrists. The treatment involves both non-pharmacological and pharmacological treatments. Non-pharmacological treatments include cognitive behavioral therapy, interpersonal therapy, mindfulness-based cognitive therapy, family psychoeducation, and electroconvulsive therapy, which is usually used for a severe or end-stage refractory depression. And pharmacological, first line being serotonin selective reuptake inhibitors, serotonin and noradrenaline reuptake inhibitors, and mirtazapine. Second line are your tricyclic antidepressants and monoamine inhibitors for treatment refractory depression. Cognitive behavioral therapy. The main aim of this is to identify maladaptive behaviors and beliefs, and it challenges these, and it uses the ABC model. So A stands for incidence, so you ask a patient about an actual event that has happened and how the patient would interpret the event immediately at that time when it happened. And then you want to ask, what does the patient believe about the event? What is the evidence for such a belief? Are they rational or irrational beliefs? And the consequences. What happens after they believe these things? What emotions do they experience? And what are their thoughts? And ask whether these consequences are appropriate to the belief and the activating event. It also teaches coping skills. Usually, cognitive behavioral therapy lasts 12 to 20 weeks, and patients undergo a booster at 3 to 6 months. You can do it one-to-one, but an increasing number have used web-based programs, which have increased the ability of patients to do it flexibly and to do it at home as well. And these web-based programs are really advanced now in that they can even notify their local doctor and the pharmacy about when the patient is struggling. IPT stands for interpersonal therapy and addresses the trigger for the patient's depression. It identifies problems to strengthen interpersonal relationships, and by doing these two, it reduces psychological distress. Mindfulness-based cognitive therapy is allowing the patient to become more aware of one's emotions, because being aware of them means that they become more able to deal with them. Family psychoeducation is essentially teaching families to better support their loved ones because of the strong relationships that are built, and they know the patients themselves, so they're able to support them in an effective way. Electroconvulsive therapy. Now, this is quite interesting, and it's mainly used for treatment refractory depression, and the way they do it is that they induce seizures via electricity under general anesthetics. And interestingly, it is the most effective form of treatment, with an 85% success when it's used as first line and 50% as second line. The problem is that it does have side effects, such as anterograde memory loss, which is usually short-term, retrograde amnesia, stigma, and general anesthetic risk. It's also first line for other diseases such as severe suicidality, catatonia, extreme poor self-care, and an elderly person who is not able to use SSRIs. In terms of pharmacological treatments for depression, it's important to keep in mind that all of these take 4 to 8 weeks to work, and you really need to counsel the patient that they have an increase of motivation and energy before their mood improves, and so they may become have more energy to suicide, and so that they should keep this in mind if they have such thoughts. And you also want to keep a close eye when they're starting antidepressants in the first 4 to 8 weeks. In terms of first line, SSRIs, SNRIs, and mirtazapine, they're safe, they're better tolerated, there's very few side effects, you only take them once, so there's better compliance, and they work by essentially blocking the postsynaptic serotonin receptors and presynaptic alpha-2 inhibitory receptors. Second line are usually used for treatment-resistant depression. So examples of SSRIs include citalopram, paroxetine, and fluoxetine. SNRIs include venlafaxine, duoxetine, and the precautions for all of these three is that it lowers the seizure episode for seizure threshold for epilepsy. It can provoke a manic episode for bipolar disorder because it increases energy. And if they take monoamine oxidase inhibitors or moclobemide, you have an increased risk of serotonin toxicity, leading to autonomic instability, hypothermia, and seizures, eventually leading to coma and death. The side effects with these drugs is sexual dysfunction. They lose their libido. They also have rebound anxiety, insomnia, mood disturbance. Mirtazapine is very well known for gaining weight, around 6 to 10 kilos. Headache, GAT, they have nausea and vomiting. Tricyclic antidepressants include amitriptyline and imipramine. And the precautions with tricyclic antidepressants is that it is lethal in overdose. You can get comas, convulsions, QT prolongation, but TCAs are effective, especially for melancholic depression. The side effects of TCAs include sedation, weight gain, and orthostatic hypotension, which is quite important. So if you have an elderly lady who has quite low blood pressure and she gets dizzy when she stands up, you don't want to be giving this drug to her because she could stand up, become very hypotensive, and essentially fall over as a syncope. Anticholinergic effects, so they get dry eyes, mouth, and urinary retention. Monoamine oxidase inhibitors include phenylalanine and mecoblamide. It's very useful for atypical depression. The risks with it is that you can get serotonin syndrome, especially if you combine it with SSRIs. It lowers the seizure risk for epilepsy, increases the risk of manic episodes, and you can have hypertension and exacerbate angina. Again, it also causes orthostatic hypotension, and there's this cheese effect whereby patients can get very, very high blood pressures, known as a hypertensive crisis, when it goes over 200 millimeters mercury. And this happens when they take monoamine oxidase inhibitors and have a good night out with wine, beer, and cheese, because that's very high in tyramine, and that this can lead to the hypertensive crisis. So the indications for combining cognitive behavioral therapy and antidepressants are for those who have severe or chronic depression, elderly, or those who have severe suicidality. People who have severe suicidality need urgent pharmacotherapy, and then they need psychotherapy to challenge the underlying beliefs that drive behavior. Some questions that I raised are: why is the burden of depression still so strong, given that we can diagnose and treat it? So there are many reasons behind it, and these just list a few. Depression has multifactorial causes. It's very difficult to diagnose, and patients often don't present with the obvious symptoms. They can somaticize, whereby they just say, oh, I have a bit of abdominal pain, or they just deny that they're sad. Other things is that they could have drug and alcohol problems, and this definitely does make depression much worse and harder to treat. And there is stigma and psychosocial around depression that makes it difficult for patients to present and seek help, because they could believe that diagnosis will affect work and relationships and would rather not get diagnosed. Believes that treatment is ineffective, that SSRIs and talking CBT doesn't work, as well as the fear of, as well as the actual medication side effects, which happen in a fair portion of patients, and does reduce their compliance with the medication. In terms of risk factors for suicide, patients who've had a previous attempt, psychiatric disease, substance abuse, serious pain, males are more likely to have successful suicides, exposure to another person's suicide, access to the means such as a car or a gun, stressful life events such as bullying, family history of suicide, or childhood abuse. And I just wanted to outline these are the well-known depression symptoms in young patients. And in elderly patients, it's similar to young patients, with the addition of usually elderly people are more stoic and they complain less. And the persistent anhedonia is not responsive to pleasurable stimuli. They have more psychotic symptoms and weight loss, impaired executive function, and associated cognitive impairment and cerebrovascular disease. So that's the end of my presentation on depression. I hope that was useful. I think depression is a serious condition within our society, and it's important to recognize it, and that there are a lot of very effective treatments out there for patients with depression, and that people need not to be afraid of being diagnosed with depression, because it's better to be rid of it and learn how to cope with it than to have it. So yeah, thank you. I hope that was useful for you.